Welcome to Module 3, a review of Form CMS-416 specifications lines 1A and 1B. This module is part of the CMS web-based training for Form CMS-416 dental data reporting. Please visit the CMS web-based training homepage at medicaid.gov to find links to modules covering additional topics. There you will also find a document that contains links to all the resources mentioned in this module. For questions about the Form CMS-416 or the Oral Health Initiative, you can access the complete Form CMS-416 reporting instructions in the Instructions for Completing Form CMS-416 file posted on the EPSDT page on medicaid.gov, or email the EPSDT Technical Assistance mailbox at epsdt@cms.hhs.gov. This module will cover several learning objectives and additional content related to Form CMS-416 specifications on lines 1A and 1B. After completing this module, you will understand notes A and B on page 1 of the Form CMS-416 instructions and how they relate to the dental lines. You will understand how to calculate both the number of eligible individuals, also known as eligibles, for EPSDT, which corresponds to line 1A, and the number of eligibles with at least 90 days of continuous enrollment, which corresponds to line 1B. You will also know how to perform data quality checks for lines 1A and 1B. The content covered in this module includes the importance of lines 1A and 1B, determining the correct age range in which to report based on date of birth, and data quality checks for lines 1A and 1B. Let's first look at line 1A, the total individuals eligible for EPSDT. More specifically, line 1A is the total unduplicated number of individuals under the age of 21 enrolled in Medicaid or a Children's Health Insurance Program or CHIP Medicaid Expansion Program determined to be eligible for EPSDT services, also known as eligibles. The count of individuals should be distributed by age and basis of eligibility as of September 30th for the reported fiscal year. Here, basis of eligibility refers to the category of need, such as medically needy or categorically needy, under which an eligible is enrolled. On the next slide, we will review more information about determining the basis of eligibility. States should determine the basis of eligibility consistent with the instructions from the Transformed Medicaid Statistical Information System, or TMSIS, data dictionary, in consultation with state Medicaid eligibility officials if needed. More information is also available about Line 1A, the CHIP Medicaid Expansion Program, and the TMSIS data dictionary from the resources listed in the accompanying hyperlink document on medicaid.gov. The Form CMS-416 is an annual report used by states to communicate important data about EPSDT service utilization in Medicaid and in those CHIP programs implemented as expansions of Medicaid. This form is an electronic Excel spreadsheet that is set up to perform certain arithmetic functions automatically. It cannot be modified by state users. Once each year by April 1st, states report data from the past federal fiscal year, which runs from October through September. Data should be entered into the spreadsheet as downloaded from medicaid.gov and submitted to CMS in the same format. Now let's talk about the different categories of eligibles. Some states have two categories for Medicaid-eligible children. These include categorically needy and medically needy. Categorically needy, represented as CN on the Form CMS-416, refers to specific categories of mandatory Medicaid eligibility established by the federal government, such as children and persons who are aged, blind, or disabled based on income levels. Medically needy, represented as MN on the Form CMS-416, refers to the option states have to extend Medicaid eligibility to individuals whose income is too high to qualify for Medicaid, but who have high medical expenses. Some states with medically needy programs do not extend EPSDT benefits to these enrollees. You will need to check with your state Medicaid agency's eligibility expert to determine whether the EPSDT benefit is available to medically needy enrollees. Data for eligibles in these two categories should be calculated and reported separately. Those data will then be summed into a total. It is important to note that the eligibility category for a child may switch in the middle of the federal fiscal year, which is the reporting period. For the purposes of Form CMS-416 reporting, only include a child in the category which they were in as of September 30th of the reporting year. Let's talk a little more about who not to include and who to include when reporting Line 1A. When counting eligibles for Line 1A, do not include children in separate CHIP programs, even if they are eligible for EPSDT benefits in your state. Children in a medically needy group, but only if your state does not provide EPSDT services for them. Undocumented immigrants only eligible for emergency Medicaid services, or individuals under 21 who are only eligible for limited services. When counting eligibles for Line 1A, you will want to include medically needy group, but only if your state provides EPSDT services for them. Medicaid eligibles under age 21 regardless of whether they have been informed of EPSDT services or have accepted them. For this group, states are responsible for informing beneficiaries about the availability of and their access to EPSDT benefit services. Finally, you should include individuals for whom third-party liability is available. Please visit Medicaid.gov for more information on third-party liability. Next, let's talk about Line 1B, the total individuals eligible for EPSDT for 90 continuous days. Line 1B includes the total unduplicated number of individuals under the age of 21 from Line 1A who have been continuously enrolled in Medicaid or a CHIP Medicaid expansion program for at least 90 continuous days in the federal fiscal year and determined to be eligible for EPSDT services. The count of individuals should be distributed by age and basis of eligibility as of September 30th. Here, the basis of eligibility refers to the category of need, such as medically needy or categorically needy, under which an eligible is enrolled. More information is also available about Line 1B at Medicaid.gov. As with Line 1A, it is important to know who to include and not to include in the count for Line 1B. When counting individuals for Line 1B, do not include individuals who are not eligible for 90 continuous days. For example, an individual was enrolled from October 1st to November 30th, a total of 60 days, and again from August 1st to September 30th, another 60 days. The total number of days this person was enrolled is 120 days, but the maximum number of continuous days he was enrolled is only 60 days. You do not count this individual because this person was not enrolled for at least 90 continuous days. Remember from the previous slide that 1B is a subset of 1A. So who do you include when counting for Line 1B? You would include individuals from Line 1A who are eligible for at least 90 continuous days. For example, an individual was enrolled from April 15th to September 15th, a total of 153 days. The total number of days this person was enrolled is 153 days. The maximum number of continuous days she was enrolled is 153. You would count this individual because this person was enrolled for at least 90 continuous days. Let's talk more about why lines 1A and 1B are important. Lines 1A and 1B are important because they help states understand how many children are eligible for EPSDT services. The data reported on most of the screening and service lines on the form are a subset of the data reported on line 1B. Also, line 1B serves as the denominator for the oral health quality metrics derived from Form CMS-416 data, such as the PDENT measure from the child core set. PDENT, or Preventive Dental Services, tracks the percentage of individuals ages 1 to 20 who are enrolled in Medicaid or CHIP Medicaid expansion programs for at least 90 continuous days, are eligible for EPSDT services, and who receive at least one preventive dental service. PDENT is calculated by taking the total number of children ages 1 to 20 in line 12B and dividing that by the total number of children ages 1 to 20 in line 1B. For more information on the Child Core Set, please visit the CHIPRA Initial Child Core Set of Children's Health Care Quality Measures page on Medicaid.gov. Let's talk more about how the structure of CHIP programs impacts reporting lines 1A and 1B. Children's Health Insurance Plan, or CHIP programs, can be structured in a few different ways in states. They can be implemented separate from the Medicaid program. These are called separate CHIP programs. Under this option, states use federal CHIP funds to finance coverage for children with higher family incomes in a program structured separately from Medicaid. As of July 2014, 13 states had separate CHIP programs. They can also be implemented as an expansion of the Medicaid program. These are called Medicaid expansion CHIP programs. Under this option, states use federal CHIP funds to expand Medicaid coverage to children with higher family incomes, so these children become part of the Medicaid program. As of July 2014, 8 states and the District of Columbia implemented Medicaid expansion programs using CHIP funds. Finally, CHIP can be implemented as a combination of the separate and expansion approaches. These are called combination CHIP programs. Under this option, states use federal CHIP funds to finance coverage for children with higher family incomes using a combination of Medicaid expansion and separate health insurance program approaches. As of July 2014, 29 states used a combination approach to using CHIP funds to provide access to health care for these children. It is important to note that children in separate CHIP programs are not reported anywhere on the Form CMS-416, and that children eligible for EPS-DT benefits as part of a Medicaid expansion CHIP program should be counted on lines 1A and 1B and also on line 1C, which is the total number of individuals eligible for EPS-DT under a CHIP Medicaid expansion program. More information about the CHIP program and states' election of CHIP implementation options is available on the CHIP State Program Information page on Medicaid.gov. When reporting in lines 1A and 1B, it is important to accurately determine which age range is appropriate for each child or service you are reporting. You should report all data, including eligibility, services, and screenings, in the age group reflecting the individual's age as of September 30th of the reporting year. This means that all data relevant to an individual child should be reported in the same age category across the entire Form CMS-416. The federal fiscal year is from October 1st through September 30th. For example, federal fiscal year 2016 is October 1st, 2015 through September 30th, 2016. Let's review a couple examples of how to determine which age range to use when reporting an individual child's data. For our first example, we'll assume we are reporting for federal fiscal year 2016. Let's say a child was born on January 12, 2014. This child would turn 2 years old on January 14, 2016. On September 30, 2016, which is the end of the 2016 federal fiscal year, the child would still be 2 years old, so you'd include him in the 1 to 2 year age group on lines 1A and 1B. In our second example, we'll still assume we are reporting for federal fiscal year 2016. Let's say now that a child was born on August 23, 2010. This child would turn 6 on August 23, 2016. She would still be 6 years old on September 30, 2016, the end of the 2016 federal fiscal year, so you'd include her in the 6 to 9 year age group on lines 1A and 1B. Now it's time for a pop quiz. Let's take a moment and see if we can determine which age range is appropriate for Ronaldo. Ronaldo's date of birth is November 12, 2008. For the Form CMS-416 Federal Fiscal Year 2014 reporting period, in which age group should he be counted as an eligible on lines 1A and 1B? Is it answer A, less than 1 year, answer B, 1 to 2 years, answer C, 3 to 5 years, or answer D, 6 to 9 years? Take a moment and think about your answer to this question. Remember, the right age group for Ronaldo is where he falls as of September 30th of the reporting year. How old was Ronaldo on September 30th, 2014? If you answered C, 3 to 5 years, you'd be correct. Great job. 3 to 5 is the correct age group because Ronaldo would turn 5 years old on November 12, 2013, and would still be 5 years old at the end of the federal fiscal year on September 30th, 2014. Some people may be confused by the fact that Ronaldo turned 6 in 2014. But since his birthday falls after September 30th, which is the end of the reporting year, he is counted as a 5-year-old for this reporting year. You correctly identified Ronaldo's age group as the one in which he fell as of September 30th, 2014. Next, we're going to spend a few minutes discussing some common issues that arise when reporting lines 1A and 1B. One common issue is when a beneficiary transitions between fee-for-service and managed care. One common process in many states is for new Medicaid enrollees to be temporarily assigned to a fee-for-service or FFS plan before being permanently placed in a plan administered by a managed care organization or MCO. These individuals will often have different Medicaid identifiers in the MCO and state FFS eligibility files. Therefore, it's good practice to deduplicate these eligibility files by matching variables other than Medicaid ID, such as date of birth, social security number, or address. By deduplicating the files, you can help make sure each child shows up only once on line 1A and only once on line 1B. Let's talk about this deduplication process a little more. In many states, all claims and encounter data are collected and then consolidated at the state level. Deduplication, or ensuring that each child has a unique Medicaid ID, is a basic function of Client Information and Medicaid Statistical Information Systems, or MSIS. Lines 1A and 1B should be drawn from the master eligibility file after deduplication. In some states, MCOs or other entities may provide aggregate encounter data reports, which the state then combines with their fee-for-service claims data. In these cases, like we discussed on the previous slide for eligibility files, children may be duplicated in the encounter and claims files since they may spend part of the year in fee-for-service and part in an MCO. Thus, it will usually be better to take the numbers for lines 1A and 1B from the master eligibility files since they should include all children whether in fee-for-service or managed care. So, how do we ensure data quality? There are 4 main components of data quality. These are completeness, consistency, accuracy, and documentation. Performing checks for each of the components of data quality will help ensure that your Form CMS-416 submission will meet the program requirements. Completeness refers to the extent to which your dataset contains all the information needed. In reporting Form CMS-416 dental data, typical completeness checks include whether you've captured data from the full member population, all provider types, all delivery systems, all plans, all payment methodologies, and all services. Consistency refers to whether you apply consistent logic in assembling and calculating your information. In reporting Form CMS-416 data, consistency often comes into play when pulling claims that match the population that you are trying to represent. For example, if you run a query that identifies the pool of eligible Medicaid enrollees, it makes sense to run future queries calculating the services delivered using the same program that generated that initial pool of eligibles. Accuracy refers to how close your data are to representing reality. In reporting Form CMS-416 data, accuracy checks typically involve referencing other data or reports to help identify unexplained variation. Documentation is how you explain the process for your data calculations, the structure of your data, and any manipulations you applied. In reporting Form CMS-416 data, documentation is critical to ensuring that your data can be understood, interpreted, and reproduced by any user. In the next slides, we will walk through each component of the data quality review for line 1B. We will discuss what each check can include and how that check can enhance the quality of your Form CMS-416 data. Next, we are going to walk through each of the 4 components of data quality. For each component, we will consider a short set of questions you should ask yourself about your data and your data collection. Altogether, these 4 sets of questions make up a data quality approach that we recommend you carry out each year before submitting your Form CMS-416 data to CMS. We'll start by performing a check of data completeness. Here's the first question. If you combine data sets that may have contained duplicates, have you checked that you are not double counting individuals? If you answered no, remember that deduplicating your pool of eligibles is a critical data quality check. Try running a query to identify potential duplicates using fields such as member ID number, date of birth, or social security number. If you answered yes, great job. One technique to ensure you don't have any duplicates is to run a query to identify potential duplicates using fields such as member ID number, date of birth, or social security number. Here's the second question. Do the data you have represent the entire Medicaid and CHIP population that is eligible for the EPSDT benefit? What about all relevant providers, plans, services, and alternative payment methods? If you answered no, remember that before you submit your data, you should check with your database administrator to make sure you can access all the necessary data. At the very least, make sure to document which populations are missing from your calculations when you submit the Form CMS-416. If you answered yes, great job. Keep in mind that no data set is perfect. Make sure to document any populations that are missing from your calculations when you submit the Form CMS-416. And remember, children enrolled in separate CHIP programs should not be included in your reporting for the Form CMS-416. This is true even if you provide the equivalent of the EPSDT benefit to children in your separate CHIP. Okay, let's move to the next step. The second set of data quality checks looks at data consistency. Ask yourself, did you start with the same data sets to calculate both lines 1A and 1B? If you answered no, remember that line 1B is a subset of line 1A. Line 1A contains all children enrolled during the reporting period, and line 1B contains all children enrolled for at least 90 continuous days. You should start with the same data sets when you calculate these fields in order to make sure the internal logic being used is consistent. If you answered yes, great job. You should start with the same data sets to calculate both lines 1A and 1B since all individuals included in line 1B are a subset of line 1A. Here's the second question to help you check for data consistency. Did you conduct a code review? If you answered no, remember that code reviews are a great way to check that the programming logic being used is consistent with the requirements for the field. Consider conducting a code review that partners the original programmer, a senior programmer for a fresh set of eyes, and the policy manager engaged in Form CMS-416 reporting in order to validate the calculations. If you answered yes, great job. You've ensured that the data you've pulled for these lines follows the rules set out in the Form CMS-416 instructions. Let's move to the next step. The third component of data quality is accuracy. We have two questions here as well. First, when you review the data, can you explain any differences in your eligibility numbers compared to data from previous years? If you answered no, remember that large differences from data reported in previous years that can't be easily explained may indicate that there is an error in your calculations. It's a good idea to go back and check to make sure there are no errors, or at least document the differences you found in the email you send when you submit the Form CMS-416 to CMS. If you answered yes, great job. Performing this check can provide a helpful indicator as to whether there are large differences between your calculations and data previously reported by your state. Now for the second question on data accuracy. Ask yourself, do lines 1A and 1B align with similar data reported in TMSIS, CEDS, or other enrollment systems? As a reminder, states submit eligibility and claims program data to CMS through the Transformed Medicaid Statistical Information System, or TMSIS, including data on long-term care services, drugs, inpatient hospital stays, and all other types of services. States also submit quarterly and annual enrollment data into the Statistical Enrollment Data System, or CEDS, for children covered through Medicaid, Medicaid expansion, or CHIP programs. If you answered no, keep in mind that one easy way to validate your line 1A and 1B results is to assess whether they align with similar data submitted through other CMS reporting systems. If your data look very different, you may be able to improve your state's reporting consistency by borrowing the processes and code used to submit data through IMSIS, or CEDS, in preparing the Form CMS-416. If you answered yes, great job. Validating your results by comparing them to similar data submitted through other CMS reporting systems is a useful accuracy check. If your data look very different, you may be able to improve your state's reporting consistency by borrowing the processes and code used to submit data through TMSIS or SEDS in preparing the Form CMS-416. The last component of data quality review looks at documentation. Again, we have two questions. When you review the data, ask yourself whether you have kept a written record of the code and specifications for your inputs, programs, outputs, and other instructions for future reference. If you answered no, remember that since reporting the Form CMS-416 is an annual requirement, good documentation will help to ensure year-over-year consistency as well as provide helpful guidance if there are questions about how your results were derived. If you answered yes, great job. Here's the second question on documentation. Have all program changes and data limitations been described in the cover correspondence to CMS? If you answered no, keep in mind that providing this information in the cover correspondence you send to CMS with your Form CMS-416 report is essential to CMS's efforts to monitor performance on goals over time. If there are any issues that impact your data, such as data from a particular MCO are unavailable, or that your state migrated to a different eligibility system mid-year, make sure to describe these issues when you submit the Form CMS-416. If you answered yes, great job. If there are any issues that impact your data, make sure to describe these issues when you submit the Form CMS-416. Let's review Module 3. In this module, you learn that lines 1A and 1B are important because they serve as the denominator for many lines on the Form CMS-416. You also learned how to determine the age group in which to report a child's data based on date of birth. And finally, you learned how to perform data quality checks on lines 1A and 1B. Congratulations! You have completed Module 3, Form CMS-416 Specifications, lines 1A and 1B. To access Module 4, other training modules, and relevant Form CMS-416 resources, please visit the Learn How to Report the CMS-416 Dental Data page on Medicaid.gov. For questions about the Form CMS-416 or the Oral Health Initiative, access the complete Form CMS-416 reporting instructions on Medicaid.gov or email the EPSDT Technical Assistance mailbox at epsdt@cms.hhs.gov.